Good morning. The topic for today is provisional restorations. So you all know the word provisional. You all get a provisional certificate before you get the original ones. So similarly, these provisional restorations are nothing but the temporary crown that you give to the patient until the final crown is cemented. Now, what is the definition of a provisional restoration? It is a fixed or a removal prosthesis designed to enhance aesthetics, stabilization, and function for a limited period of time, after which it is to be replaced by a definitive prosthesis. This is according to GPT 8. What are the other names of provisional restoration? It is otherwise called as a interim prosthesis, a temporary crown or temporization, and provisional prosthesis. Now, why do we give a provisional restoration to the patient? So this is given for a certain period of time until the permanent arrangement can be made. So this is primarily given to protect the prepared tooth and to keep the patient comfortable. This also helps in the successful treatment, and also it improves the confidence of the patient. This is an influencing factor for the success of the final restoration. What are the ideal requirements of provisional restoration? So there are basically three main requirements. One is the biological requirements, mechanical requirement, and aesthetic requirement. So under biological requirement, we have pulp protection, periodontal health, positional stability, prevention of fracture. Under mechanical, we have function, loss of retention, removal, and reuse. Aesthetics, we have the color compatibility, translucency, and color stability. Now, let me explain each of these. Now, let's start with the biological requirement. So, under biological requirement, the first one is the pulp protection. First thing that you have to remember is the material that you give as a temporary crown should be a poor conductor of heat, because during tooth preparation, the dentinal tubules will be exposed. Thus, the chance of the pulp having sensitivity will be more. So, this provisional restoration helps the pulp to withstand the sensitivity or not to irritate the pulp. Now, under periodontal health, as we all know, the restoration should have a good marginal fit. It should be properly contoured, smooth edges of the restoration and smooth surface of the restoration. Why? Because this helps to prevent the accumulation of plaque and easy cleaning by the patient and to maintain the periodontal health. Now, positional stability. This should be comfortable, okay, stable and functional occlusal relationship be maintained. Proper inter-arch and intra-arch stability should be maintained, thus preventing the migration of tooth as well as supra-eruption. What happens is the teeth will have a chance of drifting or extruding if there is no adjacent tooth or opposing tooth. So to prevent all this, we give a provisional restoration. Then prevention of fracture. So how do we prevent this? So it should protect the tooth surface from fracture, which is commonly seen in partial coverage restoration. So in which the margin of the preparation is close to the occlusal surface of the tooth and could be damaged during chewing. Mechanical requirement, that is functional requirement. Okay. So what is the main functional requirement? The main functional requirement is chewing and we also have occlusal function. So chances of teeth touching the antagonist teeth is more. So how should we control this? So this provisional restoration should have good compressive strength and flexural strength. Then whatever the material that you give or the crown that you give should not impinge the margin. It should be strong and retentive, and the patient should also feel easy to clean. Loss of retention, it should have close adaptation to the prepared tooth surface to prevent displacement and re-cementation, because if all this happens, the appointment or the patient visit to the clinic will be more. Removal and reuse. Provisional restoration can be removed and re-cemented as and when required or often. So if they are well fabricated with adequate thickness and cemented with a weak cement, it can be removed without breakage. Aesthetic requirement is mainly the shape, size, color, and texture of the restored tooth, especially if it's in the anterior region. So color stability is very important if the provisional restoration are to function for a prolonged period of time. It also serves as a guide to achieve aesthetics for the final restoration. Let's move on to the classification. So under provisional restoration, so these provisional restorations are classified according to the method of fabrication. So according to the method of fabrication, we have prefabricated and custom made. So under custom made, you have direct method and indirect method. So do you know which technique is most preferred? We prefer indirect method or indirect technique because it has more accuracy. Now, according to the material used, you have resin, metals. Under resin, you have preformed and custom made. Example of preformed is polycarbonate and cellulose acetate. Under custom made, you have acrylic and bis-acryl composite. And under metal, you have again preformed and custom made. Preformed are aluminium, tin silver, and nickel chromium. Custom made is cast metal alloy. According to the duration of use, you have short term and long term, and technique of fabrication, direct and indirect. Okay. So now let me talk about the direct technique. So this in this direct technique, you remove it directly from the mouth before it's completely polymerized. That is, you make the crown or the provisional restoration inside the patient's mouth. And this will have less marginal fit and chance of thermal insult to the pulp. Now, what are the ideal requirements of provisional restorative material? It should be biocompatible, it should have good dimensional stability, adequate strength and wear resistance, easy to contour and polish, odorless and non-irritating, chemically compatible with luting cement, aesthetically acceptable, adequate working and setting time, and easy to repair. What are the materials used? The materials used are resin and metals. So under resin, you have acrylics and bis-acryl composite. And under metal, you have cast metal alloys. Okay, so before moving on to that, let's have a quick view on this direct and indirect technique. So this picture, the first photograph shows the pre-op photograph of the patient. In the second one, the clinician has given a RPD, and with the RPD, they're making a patti index. Okay, and then moving on to the fourth picture, the patti index with the flange area can be seen in the tray. Then what happens is we apply separating medium on the tooth surface of the adjacent tooth. And then resin is mixed and poured in the index. You have to trim the flange area in this RPD. And after mixing resin to the index, we reinsert it back in the patient's mouth, then allow it to set. So this is the final restoration that we have received, which is trimmed and polished. Now in indirect technique, what we do is first we make a diagnostic cast. In the diagnostic cast, we place the artificial teeth and do a mock-up. Okay, and then this is a vacuum press machine. We place the cast and then it's vacuum pressed along with the artificial tooth. Then we do tooth preparation of the abutments. And then we make a cast of this prepared tooth and the edentulous area. Then a template is placed on the cast to check the fit. Then the template is placed on the cast with a temporary material, that is a pro-temp. This picture shows the template removed from the cast after polymerization. You place this material on the cast and allow it to set. Then we remove the template and the provisional restoration is trimmed and fitted onto the cast again. So now let's move on to the advantages and disadvantages of each material. So first, let's talk about poly-R methacrylate. So the advantage is it's of less price, less exothermic heat and shrinkage than PMMA, and extended working time. Disadvantage is it's less aesthetic, poor wear resistance, poor color stability, strong objectionable odor, hard to repair, and radiolucent. Advantages and disadvantages of polymethyl methacrylate. Again, the advantages of less cost or low cost, good wear resistance, good aesthetics, high polishability, good color stability. Disadvantages, significant amount of heat given off by the exothermic reaction, high degree of shrinkage, short working time, hard to repair, radiolucent, and strong objectionable odor. Advantages of bis-acryl composite, less shrinkage than acrylic, minimal odor, excellent aesthetics, easy to trim, radio-opaque. Disadvantages includes expensive, more brittle than acrylic, then it has a sticky surface layer that will be present after polymerization. Now these are the type of material used or the preformed provisional restoration that is available in the market. That is resin-based provisional restoration and metal provisional restorations. So we have resins, cellulose acetate, polycarbonate, polymethyl methacrylate, and poly-R methacrylate, microfilled composites, urethane dimethacrylate. And in the metal, we have aluminium, nickel, chromium, and tin, silver. Now, the cementation of provisional restoration. The ideal properties of a cement, it should be able to seal against the leakage of oral fluid. Strength consists with intentional removal, low solubility, chemical compatibility with provisional polymer, ease of eliminating excess, adequate working time, and short setting time. Cements used are zinc oxide eugenol, reinforced zinc oxide eugenol, and non-eugenol cements. Zinc phosphate, zinc polycarboxylate, and glass enamel cements are not used because they're comparatively high strength, which makes the intentional removal difficult. Now, what are the limitations? Lack of adequate strength, that is It's more prone to fracture. Okay. If the patient is a bruxer, in the long span FPDs, inadequate marginal adaptation, poor aesthetics in long-term provisional restoration, plaque accumulation due to poor surface characteristic, and compromised bonding characteristics, and mild to moderate tissue irritation. Thank you.